Assalamu alaikum. I'm really glad today to present to you Dr. Samhan Al-Ajmi. Dr. Samhan Al-Ajmi, first of all, he's my mentor and my teacher. And Dr. Samhan, he's the Assistant Program Director of the Kuwait Board of Endodontics. He graduated in 2008 from the University of Dundee, and then he received the membership of Faculty of Dentistry from Royal College of Surgeons in Ireland in 2010, and he finished his endodontic residency from University of Pennsylvania in 2014, and also a fellowship in implant from Tufts University in 2015, and at the same year he also was awarded the diplomate from the American Board of Endodontics. Dr. Samhan, the stage is yours.
السلام عليكم مساء الخير الجميع وحياكم الله. I'm very grateful that you're here in this beautiful weather outside, so really thank you for being here. And also I'd like to thank the KDA for this invitation to talk about one of the most important topics in the past couple of years, and that is vital pulp therapy. So today I'm going to give you good news that finally vital pulp therapy works in irreversible pulpitis. I'm going to show it to you today. And there has been a lot of research for decades to try to see if vital pulp therapy works, since the 70s or even before. So the change is slow but dramatic. So finally, we find the solution and how it works, and this is what we're going to talk about today. الفيتال pulp therapy من المواضيع اللي صار فيها tension in the past couple of years. لاحظنا فيينا، المؤتمر اللي بفيينا 2019 كان محور الحديث كله عن vital pulp therapy. Also Budapest قبل شهرين, for those who attended, لاحظوا ان موضوع الفيتال بالب ثيرابي هو كان center of the conference. So really very interesting recent results that we got. My interest in vital pulp therapy started more than 10 years ago. This is my first presentation when I was doing my residency, and it was about vital pulp therapy. And من ذاك الوقت, every year I have to update my presentation based on what is published, and this is the version of 2022, a major change between my first presentation and today's presentation. I also talked about reversibility of pulpitis, and that was in 2012, where I challenge what kind of things that push the status of the pulp from reversible to irreversible, and what causes the irreversibility, and how can we tell if the pulp ever goes from reversible to irreversible. I also did another presentation on marginal leakage and vital teeth, and in this presentation what I talked about is that how vital teeth respond differently from root canal treated teeth when it comes to leakage. So really I had a good background من ذاك الوقت, and if I show you the historical perspective over the past 10 years, we have more than 40 outcome studies done in the last 10 years. That includes 3,500 teeth, with the average recall is 24 months, and the recall rate is 88%, so really something good. We also had the European Society of Endodontics position statement in 2019, and also we had the AAE position statement in 2021. And this was done, the AAE position statement was done purely online during the pandemic. So this is a good achievement. And also we had, in the past 10 years, 20 meta-analysis and review papers. So the data speaks for itself. And the change is coming, and in fact, it's already here. Whether you can choose to ignore all the evidence, or you can embrace it and start practicing. You can ignore it and resist, and eventually you will follow, or you can embrace it and lead in this field. So I feel sorry, Yani, when someone comes and says that vital pulp therapy doesn't work. We have 2 position statements from the largest endodontic societies in the world. They all agree on vital pulp therapy. So I think you should start considering it. And another issue is that sometimes when someone graduates from a specific program or a specific university, they develop this dogma, aqidah. It's hard to change. They resist to change. So I think we should learn how to be open to change. And whatever I learned in the university is completely different nowadays. And that is because you have to keep open to change. If we look at the definition of endodontics from the glossary of endodontics of the AAE, it's a branch of dentistry concerned about morphology, physiology, all the way to the etiology, diagnosis, prevention, and treatment. So prevention, the word, comes before the treatment. And you need to think about how much prevention do we do? Do we do a lot, or very often we jump into treatments instead of thinking about prevention? Prevention, mafhum, in medicine, everybody is using it. If you go to a cardiologist and you have high blood pressure, they might think about prevention. They might change your diet. They might recommend changing lifestyle. They don't jump into treatment now immediately. So it's the same for us. We should think about prevention. Now, the next question is, why do we care about vital pulps? And I want you to think about 2 terms: the restorative cycle, okay, or the tooth's career. It's the same. But this term, I took it from pediatric literature, which is interesting, tooth's career. Let me explain what do I mean by the restorative cycle. Now think about a graph, and in one axis you have the tooth integrity from 0 to 100, and the patient age. And the more restorative work, the tooth integrity with time decreases. Okay? So, why is this important? It's because success is temporary. It's a temporary phenomenon. The majority of studies, the majority of outcome studies, when they do them, it's either 1 year or 2 years follow-up, right? Some studies might have 5 years. Few studies have 10 years follow-up. But really, if you ask someone what is the success rate of any procedure, such as root canal treatment, after 30 or 40 years, nobody can answer this question. Nobody knows what is the success rate after 40 years. So, for that reason, success is a temporary phenomenon. And one of the things, the good thing about vital pulp therapy, it can prolong the tooth integrity by avoiding root canal treatments to maintain the integrity of the pulp, of the tooth structure, where you don't have to place a crown, things like that. One of the papers that looked at the long-term survival of endodontic at a specialist, and that is 10 years. 10 years is considered long-term, right? If we look at the results, they looked at 15,000 teeth, and they randomly selected 420 teeth, and they looked at the survival rate is 81%. But if you place a crown immediately after the root canal treatment, success is 90%. Now, if we look at the failures, out of the failures, 6% of the failures are because of bad endo treatments. 35% due to root fracture, and 21% due to caries. So more than 50% of the failures has nothing to do with root canal treatment. In fact, it doesn't matter how beautiful your root canal treatment is. Fractures and secondary caries has nothing to do with how beautiful your root canal treatment, so that's why it's higher. Okay, so again, the benefits of vital pulp therapy. We delay the restorative cycle that we talked about. In cases where there is a mature tooth, we get continuation of root formation. It's less invasive procedure. Root canal treatment is considered invasive شوية. It requires less invasive restorations. You don't have to put crowns. Preserve the defensive and sensory functions, and that is important. The defensive, when you have a secondary caries in a vital tooth, it can protect itself by tertiary dentin, it can protect itself by blocking the dentinal tubules, whereas if it's root treated, it won't have this defensive mechanism. Also, it has a sensory function. So if you get caries in a root-filled tooth, you wouldn't feel anything at all. But if it's vital, you might feel pain, right? So this is a sensory function. Vital teeth have significantly higher proprioception. That was proved in the 80s by Stanley. Root-filled teeth showed higher caries susceptibility according to Mirdad in 2011. So many benefits. Currently, vital pulp therapy is not really popular, especially among general practitioners. And this was published, I think, last month. It's a survey to see which dental schools in the US teach vital pulp therapy. And this is a problem that we never learned in dental school, how to do vital pulp therapy. So what they found is that تقريبا 50% of dental schools, they teach them in simulation labs. And it's a 50% in newer schools, but in the older schools, it's around 30% that they teach it in simulation. If we look at who teaches vital pulp therapy in these schools, in newer schools, it's divided between endodontist, pedodontist or pediatric dentist, and also general dentists. In older schools, mainly endodontists teach vital pulp therapy. So there is a need now to focus on this and to teach in dental schools. Now, to answer this question, is vital pulp therapy possible? If you wanted to understand it, you really have to have a background in different areas of endodontics. First of all, you need to have a little background on dental materials. We'll talk about that. And then you need to understand the pulp biology and how does it respond to caries and how does it respond to different dental materials or capping materials. You also need to understand the limitation of pulp diagnosis and the diagnostic tools that we use. You need to read some papers on the history of vital pulp therapy and see why it failed in the past and what kind of methodology they used in these papers. Obviously, it goes without saying, you have to read the outcome studies that is available. فيهم عدد كبير جدا. I'm not going to be able to cover all the outcome studies. I'm going to summarize it, show you, and then it's up to you if you wanted to read more about these outcome studies. And finally, you need to read the recent position statements, both اللي من ال AAE وال ESE. I will try to summarize it at the end, but I encourage you really to read it. Let's start with the dental materials. This is a very interesting review article by Backlund and Andresen, and they wanted to see in trauma, can they replace the gold standard calcium hydroxide with MTA or not? And they showed how the pulp responds differently when you use calcium hydroxide or when you use MTA. Let me quickly explain the difference. When you use the calcium hydroxide, Yes, it's biocompatible. Yes, it stimulates sclerotic and reparative dentin. But the problem with calcium hydroxide is that it doesn't seal. As a material, it doesn't seal. It's very fragile. In fact, you can scrape it with any instruments. So it dissolves, it has a low mechanical strength, and it leaves tunnel defects. Now, when you place a calcium hydroxide directly on the pulp, what you get is that you have different layers. You will have the liquefaction necrosis layer, this one here, and then you have a coagulation layer, and then you will have your calcified bridge. This layer here, the liquefaction necrosis layer, it will dissolve, and then it will be empty, and that's why it causes tunnel defects. Let me show you how tunnel defects look like. This is a paper that was done by Goldberg in 1984, and what he did, he actually placed calcium hydroxide in premolars that is going to be extracted for ortho treatment. So he opened the pulp, placed calcium hydroxide, closed it for 3 to 4 months, and then he extract these teeth, and then look at the calcified bridge under the microscope. And what he found is that he found these tunnel defects. This is going to be a problem and challenging. If you take an X-ray of this calcified bridge, it will look beautiful on the X-ray. But what you don't see is that these tunnel defects. So if you lose the permanent restoration, if you get marginal leakage, these tunnel defects are highways to the pulp, and it's going to cause necrosis in the long run. And that's why calcium hydroxide papers and studies, they're very successful in the first year or two, but if you give it some time, they all fail, okay? And that's interesting. If we look at the MTA, or the calcium silicate materials, the same, it's biocompatible, stimulates sclerotic and reparative dentin, but the good thing is that it has a great sealing ability. And it gives you a beautiful calcified bridge compared to calcium hydroxide. Once you place the MTA, what you get is just coagulation layer, and then you get your calcified bridge. That has been shown in many histological studies, as well as clinical studies. People who've placed calcium hydroxide, MTA or bioceramic, when they remove it completely, the calcified bridge usually underneath it is completely ما tunnel defects. Okay, so let's have a look at this, another review article that compared, but this is more clinical, يعني مو شرح الفرق ما بين الماتيريالز. And they showed that the MTA has a higher success rate compared حق calcium hydroxide, and it appears that MTA is suitable replacement for calcium hydroxide. It took us many years to realize that calcium hydroxide really is not a good material, so please do not use it. Okay, another clinical study that was published in 2019, and they included 17 papers. And if you know how to read the forest plot, basically, if this diamond doesn't touch the middle line, there is a significant difference that favors the MTA compared to calcium hydroxide, and showed in 17 papers these results. Okay, let's finalize the dental materials. Please do not use calcium hydroxide anymore. La dical, la sitting, la non-sitting, كلهم, they're not as good. And you can use any calcium silicate cements. The materials that I know is the total fill from FKJ. هذه مو دعاية. I'm not associated with any company, by the way. Endosequence, they're هم نفس الشيء. اللي ينباع بأمريكا الاندوسيكونس، اللي ينباع عندنا ال FKJ, they come from the same company in Canada. You also can use the MTA from Dentsply, or you can use the Biodentin from Septodont. The majority of the studies, they use these materials. I'm sorry حق الشركات بس they usually come to me with different materials اللي من البرازيل اللي من كوريا I don't know them. Okay, and if you wanted to use any material, it may be good, I don't know, but you need to find papers that is published that shows that it works. Okay? Enough with dental materials. Let's move on to the pulp biology. Pulp biology is interesting. This is a heavily carious tooth. And my question to you, is this definitely inflamed pulp? Is it inflamed or not? Can it be healthy? Is there a chance that this pulp underneath this caries is healthy or not? And this is what I wanted to ask and show you why I'm asking about this. Now, we know that as soon as you get enamel caries, you can get inflammation. This is احنا عارفينها من زمان. If it goes deeper, you get more inflammation. But does the pulp has a capacity of healing even if it becomes inflamed or severely inflamed? Does it have the capacity to go back and be healthy or not? Many people don't believe that, but I'll show you in this paper that was done both on humans and monkeys. What they did, they exposed the dentine to bacteria, and then they started extracting teeth. In بعد 12 ساعة, after 20 hours, after 32 hours, after 1 week, after 30 days, and they wanted to see if these pulps, with time, can heal after you expose them to bacteria. They found the highest inflammation will be after 32 hours. You can see the inflammatory cells against the dentine, والبكتيريا داخلة من الدentine, okay? But after 30 days, the pulp goes back completely healthy with tertiary dentine. So within limits, the pulp, even if it gets inflamed, it can go back to be healthy, right? And that is if we understand الكيريز as a behavior. الكيريز is not gangrene. يعني الكيريز doesn't continue بشكل مستمر. It's dynamic based on the behavior, right? So if you get more cycles of demineralization, the odontoblast is likely to die and the pulp is likely to be necrotic. But on the other hand, if you get more remineralization cycles, what happens is that the odontoblast have enough time to build tertiary dentine and build higher quality dentine and block these dentinal tubules, okay? So think about caries when you look at it. شوف الcaries, is it arrested or not? Is it white شوية? Is it darker? Think about the behavior of the caries, and based on that, you can estimate or assume what is the pulp status is. And we already know that the pulp has different mechanisms, how it protects itself. You get dentinal sclerosis. Usually, the dentinal tubules are permeable, بطلين, in healthy teeth. But if you get caries, the permeability of these dental tubules will be constricted. It can go down to 20% and sometimes completely block the dental tubules, and that protects the pulp from caries. We also get tertiary dentin as well as immune response. Altogether, these responses can actually, if the caries is not fast, the pulp would have enough time to protect itself. So, in a nutshell, the slow progressing caries, the healthier the pulp. The fast progressing caries, the more the inflamed the pulp, right? So, this is a perfect example on how a tooth with very deep caries can have a healthy and completely healthy pulp. With tertiary dentine, completely sclerotic, that is blocked, ما في bacteria dish, خلاص الpulp will protect itself, right? Now, so things to think about is how fast the caries and what is the condition of the current lesion. We talked about that already. Now, this is a patient, هذه نفسها اللي حطيتها قبل شوية. She had this lesion for more than 10 years. Caries. She brushed it. She doesn't want to do anything with it, which is interesting. I tested the tooth and it's vital. There's no any symptoms at all. And they told her it's up to you if you wanted to do anything or not. Now, let's assume there is inflammation in the pulp. How does the inflammation progress in the pulp? Does it go in increments? Or the whole pulp gets inflamed altogether? This is what we need to think about now. In the past, we had this strangulation theory, and basically what it means, if you get inflammation, the whole pulp will get inflamed, and then it will strangle itself at the apex, and then the pulp will be necrotic, right? But many papers have actually proved that it's not true. Both physiological studies, such as Van Hassel, showed that the increase in pulpal pressure is localized at the site of the lesion. The rest of the pulp is completely normal. Doesn't exist in strangulation theory. Also, histological studies showed that the inflammation is very intense at the site of the caries, and the rest of the pulp is completely normal. So it doesn't make any sense that the pulp strangle itself from inflammation. In fact, many studies have اكتشفوا بالصدفة that inflammation is only localized at the site of the infection. Mitchell Trapley showed that only rarely did the inflammation extend into the root canals, and usually the radicular part, the part at the roots, is usually healthy. Okay. So, in summary, inflammation is by increments. Start at the site of the infection, and then 2 millimeter, for example, and then it goes 2 millimeter, and then it goes 2 millimeter. Why is this important? Imagine if we remove this part and we cap the tooth, do we expect it to heal or not? Yes, صح? If we remove it. And because it's increments, if you see a patient that has a vital tooth, it's positive to cold, even if it's inflamed, you know that the inflammation is somewhere close. It's within 2 millimeter, within 3 millimeter. It's not far away. Otherwise, if the inflammation goes all the way down, then the pulp is not vital anymore, right? It won't respond to cold test by definition. Unfortunately, the most of the cases that we see, we don't know how deep the inflammation is. What we do is that we actually assess the inflammation by bleeding time. This is the only thing, it's not a good marker, but it's the only thing that we have. When we do vital pulp therapy, we see bleeding. If we can control it, then it's fine. If we cannot control it, we assume that there is more inflammation, and then we have to go deeper, right? Okay. Let's move to the limitation of pulp diagnosis. And that is one of the areas that we're struggling with. I want you to imagine this line. On this part, we have a healthy pulp. This part, we have a pulp necrosis. And in between, we have reversible and irreversible pulpitis, right? So the question is there a pinpoint where we can tell exactly if the pulp goes from reversible to irreversible based on diagnosis, based on cold test, EBT, history of the pain? Can we tell? Unfortunately, we cannot. And هذه أحد العيوب اللي we're struggling with, that our test cannot really differentiate between reversible and irreversible pulpitis. And what's even more confusing is that we know that 40% of teeth, they go all the way to necrosis without pain. So you can see the confusion, and that was, I'll show you the paper by Michelson. Now, the correlation, basically what this means that do our clinical signs and symptoms correlate with the pain or not, correlate with reversible and irreversible or not? Many papers have showed that there is no correlation between the two. There is only one paper by Rikuchi that have showed correlation between reversible and irreversible. It's only one paper, it hasn't been repeated. But that doesn't mean that we cannot do vital pulp therapy. لأن أكثر واحد سوى vital pulp therapy Rikuchi. Okay? It has some problems, this paper. They assume that irreversible pulpitis when you have bacteria in the pulp, which is, if we remove it, then we can do vital pulp therapy, right? Another problem with this paper is that it doesn't explain painless pulpitis that go to necrosis without any pain. And this is the paper that I was talking about by Michelson, is that 40% of teeth, they go to necrosis without any pain at all. Okay, let's talk about this paper. This is the consensus that was done in 2009 by Linda, and what she did is that she came up with the 2009 AAE diagnostic terms that we use today, right? And if we look carefully in this paper, you can see that she mentioned that currently differentiating between reversible and irreversible pulpitis is largely done on empirical basis, and we cannot really know if it's truly irreversible. So the AAE, they admitted from that time, but we don't have any studies to prove vital pulp therapy at that time, or enough studies. If we look at the position statement of the European Society when it comes to reversible and irreversible, at this moment it is accepted that diagnosis of irreversible and reversible pulpitis are clinically based terms. And they came up with a suggestion that there have been calls to consider new, more representative way to classify pulpitis, NIFs, partial irreversible pulpitis. Partial, I mean, I agree, partial irreversible pulpitis. لأن if you say the term irreversible, then it's automatic root canal treatment, right? But if you use the term partial irreversible pulpitis, then you can remove the irreversible part and then you can do vital pulp therapy. And I'm talking about the best terms. Also, the position statement of the AAE in 2021. Today, the focus of vital pulp therapy is broader. Practitioners may have the treatment options to consider other than pulpectomy or root canal therapy in mature teeth, including teeth previously thought to have irreversibly inflamed pulp. So according to the AAE, irreversible pulpitis is not irreversible anymore. Okay, let's move on to history. There is, I don't want to spend a lot of time on history, but you know this paper by Schweck in 1978, where they did their trauma cases and they used calcium hydroxide, and it was successful, right? And that's why, وبناء على هالpaper, we got the terms mechanical exposure, or after trauma, you can do calcium hydroxide. But if you have caries exposure, then it has to be root canal treatment. And this is where it came from. Also, another paper that is usually used against vital pulp therapy is Bartel. And what they did, and these cases are done by dental students, the success in 10 years is 13% by using calcium hydroxide. Okay? And based on this paper, a lot of people gave up on vital pulp therapy. This is also a beautiful study by Biondal. It's multi-center, 2 parallel groups, patient blinded, They did two phases. الفيز الأول they did stepwise excavation compared to direct complete excavation. طبعا what they wanted to know is that the risk of pulp exposure, okay? And then they extended the paper, the study, to compare two other groups, and that is the direct pulp capping and partial pulpotomy. And they had really very low success rate, and that is 30% and 34%. This is the history. Also, we had historical myths. We can only, in the past, we can only do vital pulp therapy on small, traumatically or mechanically exposed pulps. You remember that? Only uncontaminated exposed pulps. If it's contaminated, you have to do root canal treatment. Exposed pulps of caries tooth or previously restored tooth, that was also in the past, not anymore. Older teeth because of normal age changes such as increased fibrosis. And that has been disproved because the majority of the patient group in the newer studies are adults. Okay? Okay. We're good with time. Let's move on to the outcome studies. And it's impossible to go through all the outcome studies. I'm going to select a couple. And that is by Witherspoon. And what he did is that he did full pulpotomy in young patients, and these cases are symptomatic teeth. So he had a very high success rate, and only, I think, one case that had failed. And he was one of the early people who used MTA to do vital pulp therapy. And you know, MTA was developed in 2000 تقريبا نهاية التسعينات, بس the clinical trials are usually slower. Also, a beautiful study, a case series, was done by Bogan in 2008. He's very skilled clinician, and the patient group, as you know, he extended it to 45 years old. In the past, كان في مشكلة إن في تخوف من doing vital pulp therapy on adult patients, but he was one of the first who actually showed that it works. So these are example of the case. He stopped the bleeding by using sodium hypochlorite, either by irrigation or by using cotton pellet with sodium hypochlorite. Once the bleeding is controlled, he would fill the whole floor with MTA, and that is thick MTA. And the key really is to fill the whole floor. And the mistake that I usually see is that when you have exposure, pulp exposure, you only focus on this pulp exposure, and you forget the thin dentines in the floor that is there. Okay? So 53 cases, age group 7 to 45. He had 98% success rate in 9 years. Now, case series are good to show that it works, but usually it's not generalized, because just because he's skilled, it doesn't mean that everybody can have the same success rate, okay? So that's why clinical trials are important, and this was done by Qudaymat. So Witherspoon and Bogan showed that MTA works. Now we wanted to compare it to other materials, such as calcium hydroxide. He did partial pulpotomy, and that was published in 2007. Used either calcium hydroxide or MTA. ما كان في فرق كبير ما بين الcases. I don't know, I assume it's because they didn't follow them for a longer time. Also, Menti did compare calcium hydroxide to MTA, and this is a retrospective study that was done between 2001 and 2011. So it's a retrospective, compared both materials, and found that, hold on a second, okay. So he had caries exposure, and this is good. It's not mechanical exposure. 2029 teeth recalled. MTA had 88% success rate, 73% success rate after 4 to 11 years. Calcium hydroxide, however, 50% success in 3 years. Another interesting paper by Hilton. What's good with this paper is that they took people who are good with MTA and took people who are good with calcium hydroxide, different practices, and they did تقريبا 180 cases in each group. And then the probability of success of calcium hydroxide is 68% compared to 80%. So you took people who are already skilled in calcium hydroxide, people who are already skilled in MTA, and compared the both groups and showed that MTA is better. And this paper also interesting because they wanted to see the different age groups and the success rate between the different age groups. And what they used is they used pyridentine. And you can see that if the patient is less than 20 years old, success is very high. A little bit lower if it's 20 to 30. And then 40 to 60 years is almost 80%. But that doesn't mean we shouldn't do vital pulp therapy on older patients. If I get success of 80%, I'll be more than happy, honestly. So, okay, now, direct pulp cap. I have divided these outcome studies to different groups. Direct pulp cap, partial pulpotomy, full pulpotomy, and then I did another group, which is reversible pulpitis and irreversible pulpitis. And really, I don't want you to focus on the details of these papers, but I want you to focus on the age group. When you read these papers, look at the majority of these are done on older patients. Also, when you read these papers, focus on diagnosis, reversible or irreversible or mixed, root maturity, which material they use, and the follow-up, and you can have a sense of the success rate of direct pulp cap. Partial pulpotomy, the same issue, the same thing. في couple of studies, and again, في another thing is that sometimes you don't know if the case is a direct pulp cap or partial pulpotomy, and the definition between the two is مو واضح شوية. Once you get exposure and you stop, is this direct pulp cap? If you remove a little bit, 1 millimeter, is this a direct pulp cap or partial pulpotomy? And by the end of this, I'm going to give you a flow chart of how to deal with these cases before you treatment plan it. Full pulpotomy also is very popular. In fact, it's older. Even with calcium hydroxide, it used to work, especially in class 1 because the leakage is not as high if it's class 2. Chalishkan did interesting papers. The majority are irreversible pulpitis. But you can see that the success rate ranges from the 80s to the 90s. Now, if we look at, I did some calculation. I pulled the studies, and you can see in reversible pulpitis, we have around 28 studies. I pulled the number of teeth, it's 2,500. Average follow-up is from 12 to 24, and the age range from 6 to 88. Success rate ranges between 56 and 100%. The average is 87. Now, there's only one paper that the success was 56%. So maybe that's an outlier, we don't know. Because if we compare it to irreversible pulpitis, there is around 14 studies that looked at irreversible pulpitis, 1,000 teeth. It includes direct pulp cap and full pulpotomy, and the success ranges from 78 to 100. So by looking at this, you might think that irreversible pulpitis has a higher success rate than reversible, manageable. So let's move from clinical studies to review articles. And This is by Gweiler, and they had 23 relevant articles, and the direct pulp cap تقريبا 1,000, partial pulpotomy 200, full pulpotomy is 190. Success rate ranges between partial pulpotomy and full pulpotomy high, compared to the direct pulp cap, it's lower, 72%. I'm trying to push أسرع شوية عشان الوقت. So it's تقريبا نفس الشيء most of the review articles. So now you have a permanent tooth, whether it's open or closed apex. You remove the caries completely, you get a pulp exposure. If you don't get pulp exposure, you can place calcium silicate base bonded filling, and that's it. However, if you get a pulp exposure, then you expose the pulp enough to allow visualization, and this is key. You want it to look at the pulp and see if it's vital or if there is any avascular tissues or dentine chips. This is extremely important. When you get pulp exposure, don't stop or be scared of pulp exposure. You have to make it bigger a little bit, okay? You try to control hemorrhage for 2 to 10 minutes with sodium hypochlorite, that's fine. أنا أشوف في ناس شوية يتخوفون من sodium hypochlorite, you shouldn't. And then, if you control bleeding, then you can immediately do a direct pulp cap. If you don't, then you remove a little bit as a partial pulpotomy, or you can go ahead and remove the whole floor of the pulp, and then try to control bleeding again. If you couldn't, then you go ahead and do root canal treatment. What does that mean? It means that with these cases, with this new procedure, we don't plan to do direct pulp cap or partial pulpotomy or full pulpotomy قبل العلاج. It's not just a pulp cap, it's a diagnostic procedure. So you open the tooth, you try to control bleeding, then you decide. If you can't, then we assume this is truly irreversible if bleeding cannot be controlled at all. Okay? So the procedure is diagnostic / ما نقدر نقرر من الحين whether it's direct or partial pulpotomy. It's confusing, I know, but with time you will understand it, inshallah. General principles: bacteria control is important. Once you remove كل الكاries, you should be careful to change your burr, your instrument that touched the bacteria, so you need to think about that. Dentine debris control, you don't want to push any debris into the pulp. You have to be delicate with the pulp. Don't push it with the cotton pellet hard مثلا. You can control hemostasis by using sodium hypochlorite or saline. Avoid materials entering the pulp, سواء كانت fiber tissues من الcotton pellets. We can see that under the microscope إن في fibers من الcotton pellet. You can use caries detector. I don't use it personally, but it could be a good tool to use. And then immediate restoration is important. So بعد ما تحط البايو ceramic or MTA, place Vitrabond on top, and then you can restore the tooth immediately. Let me show you an example of, this is dentine chips, and you can see the shadow of the pulp underneath. This is very thin dentine on the left. If you expose it well, you can see healthy pulp, then you can place your bioceramic or MTA. The reason I'm saying is that when you get an exposure, when you get an exposure on this side and you only focus on this side, you might get very thin dentine on this. So you need to fill the whole floor ceiling to prevent any possibility of marginal leakage. These images I took from Rikuchi paper. This is the avascular tissues that I was talking about. Sometimes it's yellowish or whitish, and sometimes it's bluish. So, and this is the image that you're looking for, healthy pulp with bleeding control. And that's also another reason why visualization is important. Whether it's a very good loops that you use or a microscope, أفضل. If you cannot really look at the tissues, then you probably wouldn't have good outcome in الcases اللي تسويها. زين. Future challenges. Currently, we don't know if we should do vital pulp therapy to compromised teeth that will need crowns. Is it going to work with it or not? We don't know. Hot teeth that might require intrapulpal injections. We had a couple of cases. Lower molars, we tried to do vital pulp therapy, but we couldn't numb the patients, and we had to do intrapulpal. Now, if you use intrapulpal, then you shouldn't do vital pulp therapy. You already damaged the pulp. Calcified pulp chambers, that's another case. We had a case that failed recently. Is it because the volume or the mass of the pulp is not enough blood supply? I don't know. Discoloration of anterior teeth is another thing to think about. I lean towards full pulpotomy with anterior teeth than direct pulp cap or partial pulpotomy, because you wanted to place the MTA under the CAJ. 5 minutes? Okay. I apologize. راح أعطيكم الزبدة بعد شوية. Okay, so this is a case, discolored. You can remove the MTA شوية تحت the CAJ and then you can bleach it. Now, let's move to the important position statement. الحين عندنا two position statements. عندنا ال ESE and the AAE. Both of these position statements, they both agree on vital pulp therapy. And we can do it. الاختلاف الوحيد ما بين two position statement is if the tooth is asymptomatic, we shouldn't remove كل الكيريز. هذا ال ESE. The AAE, we have to remove all the caries. And أنا شوية أميل لرأي ال ESE for one reason. So, hold on a second. If you read the ESE position statement, it's detailed. It's amazing, 9 pages, okay? And they had experts in cardiology with the authors, all right? And they had all these recommendations on how to do vital pulp therapy. But if you look at the AA, it's very humble, 3 pages. I think it was quick position statement, but they recommended removing all caries. Now, في شوية اختلاف ما بينهم ودنكن, who is the author of the IAJ, شوية معصب. So he wrote a letter to the editor where he wanted to defend the ESE position statement. Okay? That يفترض, okay, I can teach you how to do vital pulp therapy, but the majority of people, they don't use rubber dam. And the majority of people do not have good visualization. The majority of people don't have even MTA or bioceramic, right? They don't even have calcium hydroxide. So I cannot talk ideally في عالم غير مثالي. This is what Duncan is talking about. And if you read this, and then a global burden of caries and patient treatment need, do we expect that كل الcaries have access to dentists that have rubber dam or microscope or MTA? No. And that's why we should consider indirect pulp cap, because it's simple. You don't need rubber dam, you don't need a microscope, you don't need expensive materials. وهل هذا الاختلاف اللي صار ما بينهم قاعد يقول ان it's neither realistic nor practical that all deep caries should be referred to an endodontist. And we need to educate general practitioners in non-elitist fashion. يعني ما نكلمهم بطريقة نخبوية أو برجوازية إن مثاليين. لا, we need to teach the indirect pulp cap because it works أول شيء. It doesn't need لا expensive materials ولا equipment. And هذا الاختلاف اللي صار ما بين ال ASE وال AAE. خلاص؟
I apologize صراحة, we ran out of time.
والله عندي معلومات بس يلا. Thank you everyone. Please, if you have any questions, let me know.